Good morning, ladies and gentlemen, chairman and co-chairman. Proximal tibial valgus osteotomy is a well-established procedure for the treatment of painful varus. However, the osteotomy is called a blind-time procedure because it is the general belief that after failure of the osteotomy or recurrent varus, second osteotomy cannot be performed and only total replacement can restore pelvis knee motion. To my best knowledge, no clinical series of repeated valgus proximal tibial osteotomy has been reported. In this study, we evaluated the quality of the results of the second or repeated proximal tibial valgus osteotomy in patients who had symptomatic recurrent varus after osteotomy. From May 1995 to June 2008, we reviewed 16 knees in 16 patients who had repeated proximal tibial valgus osteotomies for recurrent varus osteoarthritis in Police General Hospital. Most of the patients were female with a mean age of 65.9 years. The mean perioperative femorotibial angle was 4.1 degrees varus. Most of them were average 4 or 5. The mean follow-up period was 39.4 months. Most of the previous osteotomies were supratubercular or high tibial osteotomy. The repeated osteotomies were infratubercular closed-wedge osteotomy in 6 knees, infratubercular displacement osteotomy in 9 knees, and open-wedge osteotomy using iliac bone graft in 1 knee. The modified knee society clinical rating system was used for clinical evaluation of our patients. The pain was modified by rating based on the use of analgesics. We did not use pain rating of the knee society system because in the system, usage of NSAIDs or opioid, which is an important confounding factor, is not taken into consideration. Deduction points were also modified because in the osteotomy, overcorrection correlates with the long-term excellent results. Our cases had good or excellent results and were satisfied with the results. The mean perioperative knee scores of 46.5 points were improved significantly to 89.3 points at the last follow-up study. The mean perioperative pain scores was also improved to 44.7 points. The mean perioperative femorotibial angle of 4.1 degrees varus was turned to 9.4 degrees valgus. Cases demonstration. A 67-year-old woman, she had pain associated with recurrent varus knee 6 years before she had had high tibial osteotomy. An open-wedge osteotomy with iliac bone graft was performed. 7.5 years, she had no pain and was rated as good results. The X-ray film showing valgus alignment with widening of medial joint space. A 22-year-old lady, she had undergone a closed-wedge osteotomy in other hospitals some years ago. She presented with recurrent pain on her right knee. X-ray film showed recurrent varus osteoarthritis. An infratubercular closed-wedge osteotomy with jaw plating was performed. 7 years after surgery, she still had pain-free and excellent results. She had also undergone the same osteotomy on the left one for varus osteoarthritis. A 68-year-old man with painful recurrent varus osteoarthritis after high tibial osteotomy with tension band plating. A loosened tension band plate was removed and an infratubercular displacement osteotomy with dual plating was performed. 5 years after the osteotomy, he had pain-free and excellent results. While the alignment osteotomy can relieve pain in varus osteoarthritic knees, before answering this question, we should know what the causes of pain in osteoarthritic knees are. The causes of pain in varus osteoarthritic knees can be attributed to abnormal overloading in the medial compartment. The abnormal overload stimulates pain receptors in subchondral bone, and injured cartilage release inflammatory mediators, particularly interleukin-1 beta and MMP3, causing painful synovitis. If the load progressively increases, the knee becomes more vellus, which in turn causes painful overstretching of the soft tissues and subchondral microfracture. As a result, subchondral bone cysts and cirrhosis will develop, and producing painful interosseous hypertension. It is well accepted that the symptoms of osteoarthritic knees are not correlated with radiographic findings. In my opinion, the symptoms depend mainly on the knee alignment. As you see from our study, that pain was subsided after preoperative varus alignment had been turned to varus postoperatively. In some cases, even inadequate varus alignment or obliteration of joint space, but the patients had no symptom because the natural knees compensated with increasing weight-bearing area by formation of peripheral osteophytes. In conclusion, even in recurrent varus osteoarthritis after knee osteotomy, a painless mobile knee could be restored by second or repeated varus osteotomy. Thank you for your attention.
Excellent. Excellent presentation. Well documented. We are expecting some questions from the floor, please. Yes.
Thank you very much. I'm Dr. Riazi from Iran. I have a question from you. How much valgus do you increase after a second operation in the varus knee? How much valgus do you accept for relief of pain after repeated osteotomy?
You mean how many preoperative degree varus, right?
When you want to change your alignment after second operation, how much valgus do you create for the patient?
Aiming to achieve 10 or 15 degree valgus.
10.
Is aiming.
Do you osteotomy the tibial tubercle for repeated operation?
Please repeat your question.
Do you osteotomize the tibial tubercle after for the second operation or not? The osteotomy, open wedge osteotomy with tibial tubercle osteotomy or not?
Please repeat your question slowly.
For open wedge osteotomy, we can do tibial tubercle osteotomy with attachment of tibial tubercle to the upper segment or lower segment. It depends on the surgeon preference. Do you do this procedure or not?
Please translate for me, Dr. Winju.
I cannot get the question. Can somebody repeat the question slowly, please?
Sorry, it means are you doing the tibial tubercle osteotomy during your procedure or not? Or if you do it, then you transfer to distal part of osteotomy, or you're reminded in the same?
You mean tibial osteotomy?
Yeah. During your high tibial osteotomy, are you doing above, in the middle, or are you including or below?
A little bit release on the tibial tuberosity, a little bit, with open wedge. But in fact, tubercle, no osteotomy.
You are not transfer the tibial tubercle?
No. Osteotomy performed beneath the tibial tuberosity.
Sorry. When we want to correct the varus to 15 degree of valgus, it's very large open wedge in osteotomy. So the patellar tendon is a restaurant to this osteotomy. Sometimes we can do osteotomy of tibial tubercle and attach the tibial tubercle to the upper part to minimize the incidence of patella baja. Yeah. My question is that, do you do this procedure for your patient because you do very large open wedge osteotomy? Okay.
They also perform beneath the tibial velocity and not affect the length of the patellar ligament.
It's a new procedure in the literature for open wedge osteotomy with large base osteotomy on the medial side. Sometimes we can
open wedge. We have performed only one case, and I think it is a retrospective study, and I have seek the best technique for maintain valgus alignment, and usually we made only infratubercle displacement osteotomy.
Thank you.
I'm from Sri Lanka. I come from Vietnam. So thank you very much for your presentation. So in your series, I find out that there is some cases you perform a close technique and for some other cases you perform open techniques. So when do you choose the open techniques, or when do you choose the closed technique for your second operation?
The inflatable closed wedge is used for when the length is not preoperatively affected or no length difference. But this payment inflatable ostomy actually is a technique described by Wagner in Germany for about 10 years ago, but they have modified by using dual plate and change the ostomy line to the boomerang shape. I mean, this technique is similar to semi-closed and open wedge. And they use a double plate because according to the literature, infratubercle ostomy may have the more non-union rate. It is the delay union in ostomy beneath the tubercle. It is the biomechanical reason, because when you make the ostomy below the tuberosity, the tension will create on the anterior side. Therefore, you should use the anterior plate to eliminate the tension side anteriorly.
Dr. Moore from India.
Last question, please.
After having done this second or a revision high tibial osteotomy, how much duration of pain relief would you expect? And secondly, would this second surgery jeopardize your results of the total knee replacement in terms of approach, skin problems, and other issues?
Please repeat your question slowly.
Yeah. The first question part is, after the revision high tibial osteotomy, how much duration of pain relief or symptom relief would you expect in your patient, in your series?
With pain score, we use the use of analgesics. When only acetaminophen we classify as when the patient use occasionally paracetamol, we classify as mild pain. We do not relate with the activities like American Knee Society score, because this is score not mentioned about the use of NSAID.
Okay. And would your second surgery affect the results of a total knee replacement which may be required second time, which may be required certain down the line? Because rather than doing a revision, why not consider a total knee replacement immediately?
In developing countries, like Thailand, not every patient can afford total knee replacement. In my opinion, total knee replacement is absolute for old age patients more than 70 years, particularly particularly osteoporotic bone is an absolute indication in my opinion. And with the ostomy compared to the total knee can produce severe or catastrophic complication than to osteotomy.
So thank you very much. On behalf of my